So I want to welcome everybody to the Senate Health and Human Services hearing for Wednesday, the 24th. And I would ask the clerk, for purpose of establishing a quorum, to go through the roll.
Chairman Miller.
Here.
Senator Valverde.
Here.
Senator Lawson.
Here.
Senator Bell.
Here.
Senator Calkin.
Here.
Senator DeMario.
Here.
Senator Golden.
Here.
Senator Paolino.
Here.
Mr. Chairman, you have 8 members present.
Thank you. So we have many people who have scheduled to be called to testify today, and so Senator Valverde was kind enough to come in to assist me with that, to make sure it goes smoothly as possible today. And what I would like to do first is, we have one bill up for consideration, to go through that consideration, and then I will go to senators to introduce their legislation and any questions for the sponsors, and then move to the call-in testimony. With that, I'm trying to move very quickly to Senator Cano, because she also has bills in another committee. But before we get to that, I would like to consider our bill that's on the calendar first, which is Senator Lawson's bill, Senate Bill 384, an act relating to uniform controlled substances, chronic intractable pain. And as was noticed in the last hearing on this bill, before we put it forward for consideration, there was a sub-A that included many technical amendments. That sub-A has already been considered and passed, and so we go for consideration on the bill before us. Is there a motion for passage on this bill?
So moved.
Is there a second?
Second.
Can the clerk please go through the vote for that bill?
Chairman Miller.
Yes.
Senator Valverde.
Yes.
Senator Lawson.
Yes.
Senator Bell.
Yes.
Senator Calkin.
Yes.
Senator DeMario.
Yes.
Senator Golden.
Yes.
Senator Paolino.
Yes.
Mr. Chairman, you have 8 members in the affirmative, none in the negative.
Thank you. So that bill will be brought to the floor at the next available date. So like I indicated before we started the hearing, Senator Cano is trying to cover 2 committees, so I want to skip out of order and wait if Senator Lawson could wait to introduce 234, while Senator Cano introduces or explains her 3 bills that are on our calendar today: 378, 481, and 492. Senator Cano?
Thank you, Chairman, for the accommodation. Members of the committee, thank you so much. I'm going to start with Senate Bill 378. This is a very near and dear to my heart bill for me. This is the Child Care is Essential Act. If COVID-19 pandemic has taught us anything, is that there are several systematic inequalities still present in our state, particularly in regards to opportunity available to our communities of color, and the ability to secure quality and affordable child care is one example of these inequalities that affect our communities of color more than most in our state. It is for these reasons that we introduced the Child Care is Essential Act, because child care is an essential service, and every working parent and their children fundamentally deserve the opportunity to access to child quality care that is affordable. Without it, parents are unable to provide for themselves and their families, and children are left behind emotionally, educationally, and socially. This legislation in front of you would increase the rates for the Child Care Assistance Program to meet the federal equal access standard and help programs deliver high quality care. The legislation would also cap family co-pays for the Child Care Assistance Program at 7% of the family's income, which is the federal affordability standard. And finally, the bill will restore family eligibility for the Child Care Assistance Program at 225% of the federal poverty level and adjust exit eligibility to 300% of the federal poverty level. Finding quality, affordable childcare was a challenge before COVID-19, and now that the pandemic has placed even more stress on working parents and Rhode Island childcare providers. As a working mom, I know the struggle personally and have been fortunate to have childcare options for my daughter Ariana. But I know many Rhode Island families are not as lucky as I am. And that means that we need to really invest in our childcare infrastructure, ensuring that our child care providers have the resources to pay their bills, including covering wages of staff during repeated quarantines that require staff and children to stay home. That means increasing the reimbursement rates for licensed child care centers and family child care homes to increase child care assistance program CCAP rates and further expand quality child care options. So this is the time that we need to step up for these people. And Mr. Chairman and members of the committee, I encourage you to make this legislation a priority. Let's pass the Rhode Island Child Care is Essential Act to make the increased rates for the family child care assistance program permanent and to promote children's access to high quality programs and help providers meet minimum wages requirements. Safety, healthy, and high quality child care options are essential for working parents and for children to learn and grow. And with that, I'll be happy to take any questions.
I believe we already have a sub-A prepared on this also that may need introduction before we have further discussion around it.
That's correct.
Yeah. So a motion on a sub-A on 378.
So moved.
So moved.
All those in favor, clerk?
Chairman Miller,
Yes.
Senator Valverde,
Yes.
Senator Lawson,
Yes.
Senator Bell,
Yes.
Senator Calkin,
Yes.
Senator DeMario,
Yes.
Senator Golden,
Yes.
Senator Paolino.
Yes.
Mr. Chairman, you have 8 members in the affirmative, none in the negative.
Thank you. Anybody have questions on the sub-A and the changes that are within the sub-A? Senator Bell?
Sorry, my question is about the sub-A itself, not the specific sub-A changes. I understand those quite well.
Okay.
I first of all want to commend the sponsor for her work on this legislation. I think it is incredibly important that we invest in child care. And that's why I co-sponsored this legislation. The increase in eligibility is, I think, incredibly important. My question relates to something brought up to us in written testimony by SEIU 1199, which is the union that represents many family child care homes, which are an important, essentially they're really small businesses set up predominantly by immigrant women to provide child care in a neighborhood setting. And I think, these providers are people that we really need to support and don't get as much support as they deserve. And so what this bill would do, while raising rates, would also introduce reimbursement rate tiering so that rates would be tied to the tiers set up by Bright Stars, which is a private organization that provides rating. And as I understand it, while most categories of child care providers would receive increases, family child care homes with low Bright Stars ratings would receive a decrease compared to the increased pandemic rates. although an increase above the baseline rates before the pandemic increase. And I'm wondering if it would be possible to adjust the rate system so that these particular providers are not singled out for being the only group that does see these decreases, and whether we could adjust the rates to make sure that these providers who care to infants and very young children would not see a decrease compared to the current pandemic rates.
So thank you, Senator Bell. I really appreciate you bringing the concern in regards to family child care providers. Well, I understand that that is a very valid concern. This legislation really is trying to increase rates for both the child care centers and also the family child care providers. I do understand that we have a tier system that is dated 20 years ago, and we need to work in the state to make sure that there is some equity when it comes to both the child care centers and the family care centers, but this bill specifically doesn't cover that part. That we need to work on that in a separate legislation. While I understand your concern, I also want to make sure that you know that it's essential that we increase the eligibility now, and that could be worked in a separate bill. And I totally get where you're coming from. I'm certainly very concerned about those working immigrant families that definitely need the support, and I don't want to dismiss that. I think that what they do and what they've been doing ever since the pandemic started is making sure that they're there for us, so we need to be there for them now. So I totally get that. I also want to make sure that I take the opportunity to mention to committee members that the Child Care Commission, which is a commission that has many of the organizations in the table, have worked very diligently on putting together the legislation and working with many of these groups, including the family child care providers that have some input into the legislation. So I want to make sure that their voice is heard. We need to certainly do more. I don't want to dismiss that, and I want to say thank you for bringing it to the attention. And I do know that you're going to hear from testimony from different organizations that are part of the coalition. They could clarify more for you the tier system and how we could just work for making sure that it's more equitable. So I really thank you for that concern. And as much as of a specific answer, I don't have more than what I just explained to you, but we could work into it, and I'll make sure that I commit to do that.
Thank you so much, Chairwoman. And again, thank you for bringing forward this really important piece of legislation, which has so many really important advances for child care in our state. So thank you so much.
Before you go on to your next bill, I do want to let people understand that we not only have your bill that is deemed to require a fiscal note, but also Senator Lawson's 386, Senator Goodwin's 430, Senator Cano's other bill 481, and Senator Cano's other bill 492. So based on that, it would probably be recommended that we have a hold on those bills because of that issue. And the second issue on 378, before you go on to introducing your next bill, is that, and there are a couple of other bills that this same issue arises on, is that within the American Rescue Plan Act of this year, which I think was, those funds were probably passed after the bill was drafted, and there's several implications, immediate but probably not indefinite, so it doesn't totally cover the legislation, which puts a lot of indefinite improvements to child care subsidy and reimbursement. But there's $35 million for Rhode Island, it's been estimated, in child care assistance funds, and $57 million and child care stabilization funds for the providers. So I think it has to be examined on whether how quickly those monies have to be spent and what impact they have in the next few years to this type of legislation, and whether this legislation could potentially have unintentional consequences on how that money could be spent from the, so those are examples of the issues that have to be looked at before we consider this bill for passage. And it's all good, but it has to be incorporated to our consideration on this legislation.
Thank you, Mr. Chairman. If I may say that what you said is correct, and we're working on that fiscal note, as you mentioned. So hopefully we'll be able to have a estimated amount for you before we can hear this bill again. So I really appreciate it.
And I think, one of the things that first comes to mind, at least for me, is we don't want to have anything technically that triggers us not being able to access 100% of those available funds by how the bill describes what it strives to do. So, I doubt it, but you always want to check that kind of thing. Do you want to go on to the next legislation if there aren't questions around that issue?
Thank you, Mr. Chairman. I really appreciate it.
Yeah.
I think that next legislation in your agenda is Bill 481, which requires the Secretary of the Executive Office of HHS to increase income disregards to determine eligibility for certain Medicare cost-sharing programs by an amount that equalizes the income level to 185% of the federal poverty level. And this legislation is it was brought up to my attention as Maureen Magre, which is the chair, that serves as a chair of the Aging in Community subcommittee of the Long-Term Care Coordinator Council, was talking to me about how so many of our low-income older Rhode Islanders really do have a challenge to meet some of the healthcare costs that they do need when it comes to a package of legislation that they are supporting. So why is 481 important? Most seniors have Medicare. They can face significant out-of-pocket healthcare costs for premiums, copays, and service not covered by Medicare. The 2021 Medicare Part B premium for most people is $148.50 per month, which is a total cost of $1,782. This is in addition to any deductibles or co-payments required by a person, Medicare plan and Part D drug plan premiums and co-payments. Research showed that overall, out of the pocket costs for person on traditional Medicare between $5,460 and $7,473. These costs can easily take up 30% of the income for those with limited means. Why is this important? Like, I have heard for many of my constituents that I have in my district that have applied and have been denied simply because their income is like barely higher than the standard that we have right now. So by having this bill passed, we want to make sure that we are able to allow some of these seniors to get and adopt that special disregard would bring the income level up to 100% of the federal poverty level, as I said before. So I would love to, I do know Maureen is going to speak more in this legislature later, and you receive a written testimony from her as well. So I would love to answer any questions at this time.
Any questions from the committee on 481? So why don't you go ahead with your third bill then?
Thank you so much, Mr. Chairman. That is Bill 492, which is an increase the income eligibility limit for medical assistant coverage for seniors and disabled individuals from 100% to 133% of the federal poverty level. So basically, this bill goes hand in hand with the other one, and it's really about equity for people that are 65 or older with disabilities. And what it does is by raising the income eligibility for Medicaid for them, what it does is that it would help them really have parity with the thousands of Rhode Islands that already are in the age break of 19 to 64, and it would help them be part of the same bracket. And the Medicare expansion for this group was implemented with the Affordable Care Act. So we just really want to make sure that all of these groups with disability and seniors 65 and older will be able to have like the coverage for some of the services that are not covered by Medicare, and that makes sense that we are able, especially during the pandemic times, that we are able to support the seniors and people with disability. With that, I will be happy to also answer any questions.
Any questions on this? Senator Bell has a question for the sponsor. Go right ahead, Senator Bell. Senator Bell.
Thank you so much, Chairman. Chairwoman Cano, when I saw this piece of legislation, I have to say I was shocked that it isn't already current policy. It seems to me extremely abnormal that we would not have taken up on Medicaid expansion with this population. So I guess my question is, are you aware of the reason why we haven't already done this? Since if we're going to be getting federal reimbursement through Medicaid, why wouldn't we do this? Did we just choose to exclude this population when we did Medicaid expansion?
So that is that's a very good question. And I think that Maureen will be more, and she would be testifying on this, would be more, it would be more equipped to give you the history of it, like all the background of it. But what I do know is that there is no excuse for us to make sure that we give some equity to these seniors and people with disability, to make sure that we pair them with the group that is already covered, and to make sure that we follow the same standards. So I really appreciate your question, because the answer is I don't know. Maybe Maureen could help us with that. But the reason that we do this, to me, is also when she discussed these two pieces of legislation with me, it was apparent that it was a need, and it was for us to act on it now, especially during a pandemic. I think that should be priority.
So can I add to that? One of the reasons that several of these bills require a fiscal note is for this exact reason, is to demonstrate, when we ask for a fiscal note in the Senate, that when it becomes a conversation beyond the Senate, that we can demonstrate through our fiscal note that we deem it to be minimal or insignificant based on the current match. But the conversation we've gone through on this type of legislation, and this is where a fiscal note can work to our favor, is to demonstrate that. But it doesn't always work, and I'll tell you why. Is because people get speculative about this, and they'll say the current federal contribution or match could change, and therefore leave the state liable for a greater percentage of the Medicaid reimbursement. And so a fiscal note will often demonstrate where and how we disagree with that evaluation, but it might not totally get rid of the whole assessment on a bill. But these are different times with, different federal response to these kind of state issues. And so we might have different results.
Thank you, Mr. Chairman.
Yep. Senator Bell?
Thank you. I just wanted to say that's very helpful, Mr. Chairman. I was just wondering if perhaps you could clarify, because you mentioned possible changes in reimbursement rate.
Yeah.
Is this population currently under the expansion reimbursement rate of 90%, or would it be under the traditional FMAP, which is of course enhanced because of the federal state of emergency? But
Right.
is this an FMAP
This is
population, or is it a 90% Medicaid expansion reimbursement rate population? And was what you were saying that people were concerned that 90% might go away?
Especially in the previous administration, those kind of matches were always in jeopardy. So it's whether they're going to continue to be in jeopardy or people are going to continue argue that they might be. And so one thing we would get in a fiscal note is an answer to a question like that is which matches it currently is under, to be specific to those, and to explain where we are currently, and then we still have, the pushback from some advocates that is under current programs, and we have nothing written in stone that's indefinite. And that's where we've had trouble in the past on this type of legislation. Not necessarily in the Senate, but beyond.
Thank you.
Yeah. Any other questions on this one? If not, I want to thank Senator Cano. We'll get to your calls. We do have a lot of calls on several bills. It, logistically doesn't work for us to go right to your bills while you're still with us. So we're going to go through all the senators' introductions. We also have Senator Lawson and Senator Quezada and Senator Mack. Not all are on this committee, obviously, so they can't all or might not all stick around for the whole hearing, and therefore we're going to go through the call testimony after we go through all the introductions. So if we're going to keep in somewhat in order here, I'm going to try to go who's next based on posting, which would be Senator Lawson on 234.
Thank you, Chairman Miller. I'd also like to thank the committee for their support on the chronic pain bill. I think we have the ability to significantly improve lives of Rhode Islanders, and I appreciate your support. Next, I'd like to bring forth to you my newborn screening bill 234. So this bill would mandate the rules and regulations of the Department of Health pertaining to newborn screening to include at a minimum newborn screening tests for all disorders and conditions listed in the current federal recommended uniform screening panel, often referred to as RUS, and include new disorders and conditions within 2 years, unless it's not practical to include a new disorder. So I'd like to thank the chairman and his assistants on this bill, as well as Neil Heitman and Dr. Padbury and the Newborn Screening Advisory. We met over a year ago before the pandemic and had a meeting to address some concerns around the language, and we tweaked it. So the implementation would address some concerns. Just for a little information, the RUS, which is the federal recommended screening panel, is pretty rigorous process, and I think one that we should adopt here in Rhode Island. It's been endorsed by, in an article of Pediatrics and Newborn Screenings about effective public health care intervention. And the results are it decreases morbidity and mortality. And it's also cost effective for states. And I recommend we adopt the screening process.
Any questions for
Thank
Senator
you.
Lawson on this on this bill? Senator Valverde.
Thank you. Senator Lawson, do you know, are there any specific screenings that are included in this recommendation that are currently not done in Rhode Island?
When I initially, last year, I had drafted this bill because it was spinal muscle atrophy. I'd have to go back and check if there are any additional, have there been any additional changes? And get back to you.
Great.
But since then, spinal muscle atrophy, is done in Rhode Island.
Thank you.
Any other questions for Senator Lawson on this bill? Thank you. Next. Senator Lawson, you also have 386.
Thank you. So this bill would create a catastrophic illness and children relief fund here in Rhode Island. And what it would do would be to provide financial assistance to families with children 21 years of age or younger who have been stricken with a catastrophic illness for medical expenses that are not covered by any other state or federal insurance contract. So within the bill, you can see that it creates a commission where the general treasurer would be the custodian of the fund. There are 9 members on the commission. So there are various entities that participate in the commission, the director of DCYF, Human Services, the general treasurer, 5 members of the public appointed by the governor, 2 by the Senate president, the speaker, also one of each who is a provider of healthcare services to children in the state. So this would be funded by an annual surcharge per employee subject to employment security laws of $1.50 per employee. In this, there are catastrophic illness funds in both Massachusetts and New Jersey. So this bill is modeled more after the New Jersey one, and that's been around since 1989. The Massachusetts one is more recent, but that's still 2000. Right now, the most recent figures that I have to begin the fund on that, but like the chairman said, the fiscal note would be issued. I think it's around $650,000 when I received information from DLT from Matt Weldon. Thank you.
Any questions on this bill from Senator Lawson? Senator Valverde?
Yeah. Thank you, Senator Lawson. Do you know what the uptake on use of this fund might be in Rhode Island? Do you know how many families face a child with a catastrophic illness?
So I requested that from her health insurance commissioner. So what their response basically was that the commission would be set up and they would determine that they would have a better indication than at this point in time. They really, with the information, they didn't have enough information to provide that for me. That's what they said. It said they're sure once the commission meets, the group would collectively have some ideas about qualifying the scope to address some information to identify a population. So at this time, I don't. So that's, they thought, would be the best way to try and figure that out.
Okay, thanks.
Yeah, like I indicated earlier, there will be a fiscal note on this bill, and it will not only be something that could be an obstruction, it could be something that could enhance our arguing in favor of this type of legislation. But we've already, gotten some written testimony from business groups talking about during a pandemic, $1.50 per employee is a burden coming out of such difficult times. And I'm sure we have a letter, even though I might not have seen it yet, from League of Cities and Towns, same thing for city and town employees, and fiscal note would also show some concern from state employees and whether there'll be a fiscal impact to state budget for the same reasons. Doesn't mean we're not interested in it. It just means we have to consider and request it. Any other questions on this bill? If not, I'll ask well, I want to go over Senator Goodwin's bill. I don't believe she's calling in on 430, but it's legislation that would increase Medicaid coverage for eligible pregnant women for 12 months after a 1 month post-birth, and for those over 250% of the poverty level. And so that's an increase from 60 days to 12 months. And like other legislation we're hearing today, it's impacted by the American Rescue Plan, because under the American Rescue Plan, it extends that Medicaid coverage specifically for what this legislation is also targeted at. And so we have to not only look at the fiscal impact, but make sure we're being fully successful in using those funds, and that we don't do anything detrimental in this type of legislation towards the utilization of those funds. So that's something to look at before we have further consideration of that bill also. And now we can move on, if there are no questions on that bill. Senator Bell?
Thank you so much, Mr. Chairman. And I just want to make sure I understand Senator Goodwin's legislation and its interaction with federal reimbursements.
Yeah.
Have we always had the ability to get reimbursed for an additional month after childbirth? Is this a new ability that comes from the American Rescue Plan?
The ability in the rescue plan is to extend it to 12 months and they will reimburse.
I see. So this is a new ability,
Yeah.
and this legislation is done basically because of the American Rescue Plan to allow us to.
I think it was drafted before without the expectation that it would be part of the rescue plan, because it's an issue for many states that they want to extend this benefit, but it's not, they don't get any match for it. And so this covers that for states that had the ambition to go to 12 months.
I see. So we would have done this without the federal match because it's such a needy necessary investment. Now we can get the federal match because of the American Rescue Plan. That makes sense. Thank you so much. That's very, very helpful.
Yep. So next we can go to Senator Quezada for the legislation which we have had for at least a couple of years, and I believe there are some changes to this year's legislation. And if you want to help explain some of that, Senator Quezada, welcome to Health, and go right ahead.
Thank you, Mr. Chairman. Yes, like you said, this is not a new bill to anybody. Doula bill is a very, this is the third year that we have doula on this committee. And for the last 2 years, we have put it on the budget, and that's the same thing this year. Again, I want to thank before anything to all the doula advocate. They've been working so hard to put this bill together. They were the one who set up the legislation. It's so many people who worked so hard to put this bill together. I want to thank Secretary Jones, the City of Providence, who's going to send testimony. I want to thank Governor McKee for understanding. He didn't have no idea what doula was, but we were able to educate him on that issue, and it was good. But without Secretary Jones, I don't think it would be possible. Then I want to thank all these organizations who helped us to put this amazing bill together. Unfortunately, last year, because of the COVID-19, we wasn't able to do anything with doula. But last year, Governor Raimundo put this bill in the budget too, and everybody know what happened. And unfortunately, we wasn't able to do nothing. We it's being a few things. One of the things, this is going to be the only doula is only going to be able to cover women and Medicaid, unfortunately, because private insurance, because of the Obamacare is regulated. If we mandate for the insurance to pay, the state has to pay for, and you know the state is not willing to pay for that kind of service. But that's the only part that I don't think is fair because so many women of color have private insurance, and they should be able to get a doula service for them besides you have Medicaid or a private insurance. But this is not the end. We're going to continue working on this issue until we can get and make sure the private insurance understand that this is a way to save money. When a women don't know and go to the hospital for any little thing that they feel because they're not sure, or maybe when they're having the first baby, doula is very helpful. It prevent, it save money because women would be able to call the doula and they will be able to educate them, to support them, and to do so many things that they prevent women to go to emergency room, and then it's a saving, and that's what we want insurance to look. The doula is not spending money; it's saving money, and until we don't make that final term with private insurance, unfortunately, we're not going to be able to be provide this service and be paid by private insurance. But other than that, what we change is going to be a 50 is going to extend women from before. I think it was only covered to the first month. Now it's going to be covered to a whole year. That's the change that was done in this bill. After having the baby, after birth, it's going to be from the beginning of the pregnancy to 1 year after you have the baby. And I'm very happy to be able to put this in this bill because this is when women get postpartum depression. That's when they really need support. Many years ago, used to support you was just your parents, your grandparents, your family. Unfortunately, many women they don't have that support anymore. And now grandparents sometimes even they have to work because the income that they receive is not enough, or they don't live close by, or they coming new from another country and they don't have the support that they used to have. Then doula become that support. They became the family. They became somebody who's going to be there to ask them to answer any question, to give them a hug or to listen to them or to be able to support these women and those so necessary when you have a baby. It's such your body goes so many changes, and only women can know this because we already had babies in the past. I'm a mom of 3 children. Then I can relate it. I didn't have no information 3 years ago what doula was. And when advocate came to me and said to put this bill, I was somebody who had to educate myself and find information what doula was. And I'm very happy to support this legislation and to be the face. But it's so many people behind this bill that without them, I would not be able to present this. Without this, I would be able to answer any question you may have. Thank you, Mr. Chairman.
So it would be interesting to look at it with Senator Goodwin's bill, to look at them together. Not that they would go together, but that whether they have any impact on each other. And also, we do have written testimony from Blue Cross and their evaluation and understanding about doula services, that they do support the legislation with changes. I don't know if they've gone over with you, Senator Casado, what changes they're interested in, But there are insurers, and one of them is in Rhode Island, who understand doula enough to know that everything we've done to discuss and let people understand what a doula is, they understand it, that the fiscal impact, to use language that we've used before, on covering doulas can actually save money. And I think they've arrived at the same evaluation. So the whole world isn't against us on this. And I think it's also fair to say, if the advocacy, not only from you, but many of the other people who've been involved in this legislation, without that, we wouldn't have gotten to the point where there's enough of an understanding, not only that an insurer such as Blue Cross understands it better, but Governor Raimondo and now Governor McKee understand it enough to have it as a budget item to enhance the legislation and further understand it. So I think we're on a real good momentum around this type of legislation. But there are a couple of changes we should consider around this, including looking at what Blue Cross has to recommend as amendments to this.
I didn't get any information from Blue Cross, but now that you mentioned it, I will look into it.
Yeah.
I know Women and Infant is very supportive of this legislation.
Yeah.
And that is a good resource for Blue Cross or for any private insurance who wanted to know more about it. And I think they can give them the data. That's the most important thing, how much saving and it can be for any kind of insurance who provide doula service through the insurance. Another, I know it's a letter that they sent to you with 900 people who signed it. And that was a way to prevent so many calls. You know, this is a bill that has so many follow and so many people who want to go and give the testimony. This afternoon, I was getting phone calls for people who wasn't able to sign up, but I told them we know how much people is approved of doula, and I want to thank each one of them. Thank you, Chairman.
Yeah, so this is I think a record breaking package of written testimony that I've seen for this committee, and part of it is because we do have those 900 signatures in here on the doula legislation. So it's a very thick packet of written testimony, and part of it is because we do have that. Senator Bell has a question.
Yeah, I have to say I'm very concerned about the idea that we would take such an incredibly popular piece of legislation, something that has such overwhelming public support, and really such a strong, compelling moral need for us to pass, and water it down just to please the insurance companies.
It's not to please them. It's not to please them in any way. It's to bring them into it. It's really to bring them into it. They've recognized the value, and if they have technical or grammatical changes on that, any changes to this bill going forward in the next week or two would be on behalf of the legislation, and would not be to compromise the legislation. In no way we would, and I don't want to speak for the sponsor, but in no way we would consider an amendment from the insurer that would diminish the impact of the legislation. But we have to discuss it with them so that we can have full cooperation on it. And it's a great example of we will not, at least me as chair, and I know the sponsor, will not diminish the intent of the legislation. And the intent of the legislation, like we said, we've gone too far to have the legislation compromised by errors or not considering the issues of others we want to participate. And so I think it's very important to do that to any legislation, including this one.
Thank you, Mr. Chairman, and that's true. We just want.
I would like to
understand the importance of doula, and we want them to pay for those services. So many women would not be able to participate in doula if the private insurance don't get the service, Senator Bell.
Thank you, Senator Quesada. And Chairman, I hadn't finished speaking when you added that contribution. As I was going to say, I am concerned that by excluding the private market, that is a very, very significant change to this legislation, and removing private health insurance from this market. I was unaware, actually, that this new version of legislation excluded the private market, which is the majority of our healthcare system. I think that is very significant, and in addition to the changes that apparently Blue Cross is now looking for, I'm wondering how we can get back to having the private market included in this legislation. And if it requires the state to pay for it, the costs here are really not very high, and I'm unclear why the state would not be able to pay for that legislation. And I'm concerned about this legislation being compromised down. If it does require state funds, the state funds in the past, at least for the Medicaid market, have not been high. So I'm wondering if you could clarify, Senator Quesada, the exact limitations in the ACA that prevent us. And I understand if you don't have it right now, but I would wonder if it would be possible to get us the exact language and citation from the ACA that does create this technical problem that limits us from being able to mandate this in the private market.
I don't have that information with me, but it's not that the state is not willing to pay. They are willing to pay through Medicaid. We just want to find a way, and I'm glad that Blue Cross want to be on board to start the private insurance phase, and not without the state doing it. And that's the purpose. We don't want to put more burn to the state budget if we can get the private insurance to pay. I think we just need to work with them and listen, sit down with them at the table, hear the proposal. And it's not a lot of money. $850 is not like it's so much money to pay for a doula service. I think if we are able to provide the data to the private insurance and see how much money they're going to be saving, that will be a win-win for them, for the mothers, and for everybody who participate in this service. I think we're not going to have no problem getting the private insurance to enjoy us and not just to do it through Medicaid. I was very upset last year. I think it was last year or the previous year that I received a letter from a few private insurance refusing. And then they even said and recognized there wasn't that much money the doula was able to to pay, but they didn't want to do it. And they knew there was no way for us to make them to pay, only if the state decide that the state then has to pay for it. Then.
Right. So what I was saying was, if apparently there's these limitations in the ACA, I do think it's important enough actually that we would make that investment ourselves.
Oh, no, I agree with you.
Yeah, so I want to clarify two things that has come up in the explanation on this bill and why we want to continue a dialogue with Blue Cross is not to exclude them. It's to keep them included. The legislation explicitly includes them. So I don't know where that misunderstanding came from. And also the budget item specifically requires and includes Medicaid. So there's been some misunderstanding maybe on the way it was presented or the way the introduction to the bill is written. But for some reason, there's a misperception about both of those. The governor's budget, and thankfully, based on the advocacy of Senator Quesada and others, the budget item covers the Medicaid component of it, and the legislation specifically describes and requires private insurance to also pay for the services. And our continuing dialogue with Blue Cross and others around how they would change it is for no ambition to change that inclusion. That is not why we're continuing a dialogue with a private insurer. It's to continue that. But if in the effort to continue that, they have either a technical or a policy adjustment in it, we want to hear what that is as long as it doesn't diminish the intent of the legislation.
Thank you, Chairman.
Thank you so much, Mr. Chairman. That does clarify it. I was alarmed at the idea of the private market being excluded.
No, their intent, they support the legislation in concept, and we need to look very carefully at what language changes they want. We're not looking to talk to somebody who doesn't fundamentally support it, which they do. We're looking to talk to somebody who fundamentally does support it, which Blue Cross does, and we want to continue that engagement so they continue to support it. And if it means some language changes, we want to see what they are. Senator Calkin.
Thank you, Mr. Chair. So I just want to be 100% sure about this. So there's nothing currently in the ACA that would prevent us from putting this in place here in Rhode Island.
Oh.
If you're talking about the mandate component of it, we believe currently it would not endanger that. It has been carefully written not to cross that line, but it's something to be examined before we hear it again with a sub-A.
Thank you.
Yep. Any other questions before we go to, I think, the last introductory we want to hear from a senator would be Senator Mack on Senate Bill 593. Senator Mack?
Thank you, Chair Miller, and thank you, members of the Health and Human Services Committee. This bill will help preserve the right to bodily autonomy for all Rhode Islanders, particularly infants and young people with variations in physical sex characteristics. What this bill does is it defines a list of medically unnecessary surgeries performed on individuals with variations in their physical sex characteristics and prevents infants and young people from undergoing these surgeries before the age of 12. This bill will help ensure that life-altering choices about a person's body are honored, respected, and patient involvement is centered. Approximately 1 to 2% of people are born with variations in bodily sex characteristics, such as genitalia, reproductive organs, and chromosomes, sometimes referred to as intersex traits. This is about the same number of people in our population with green eyes or with red hair. This bill also provides parents with the opportunity to observe their child's development and perspective on their own bodies so they can follow their child's lead in these very personal decisions. It will also help parents to center bodily autonomy for those born with variations in their physical sex characteristics in the most effective way and support parents in decision-making with the best interests of their child at heart. Intersex is an umbrella term, and there are many ways the typical process of sex development can vary, and there are over 30 medical terms for specific variations in sex traits. People with these variations have always existed, and awareness is increasing about the diversity of human bodies. People whose bodies are different from what society expects should have the same body autonomy, dignity, and respect as all other Rhode Islanders. If passed, Rhode Island would be joining 2 other major children's hospitals, Children's Hospital in Chicago and Boston Children's Hospital, that have recently banned some of these surgeries. This is also, there's also legislation in California, New York, and Connecticut. More than 30 countries have also condemned these medically unnecessary surgeries. And I would like to thank the lawyers and activists and team at Interact for leading on advocacy and policy change across the country. There's also been a petition signed, not nearly 900 signatures, that the doula bill, which I'm super happy as has its hearing tonight, but there is a petition that was signed and circulated by a Harvard Med student and activist, Casey, with 564 devoted medical students, physicians, healthcare, and Brown alumni and Rhode Island residents. And I look forward to working with this committee over the upcoming weeks and months to push this important legislation for bodily autonomy and protect our young people. Thank you, and I look forward to your questions.
Any questions for Senator Mack on her legislation? I want to thank you for presenting and bringing this issue to the forefront by writing this legislation. If not, we'll go to the calls at this point. Before we go to the calls, I just want to make one point. Seeing as some were concerned that there might be a component of lack of respect or understanding on why we might make motions before the bills, I'll keep close attention to that we maintain a quorum, and if it looks like we're maintaining a quorum until we're finished with testimony, we can wait that long to have motions on these bills. If I see the quorum diminishing, I might ask for a motion while we're taking the calls, pause from the calls, and take a motion on these bills before we finish calls, okay? Just so people know what we're up to. With that, I'll go to the call list, and we'll start with Alistair Idelson, I believe. So, Alistair, you're on with the Senate Health and Human Services Committee. Please state which bill or bills you wish to testify on. And if you're not speaking on behalf of yourself, let us know what organization or entity you're speaking on behalf of.
Sure, absolutely. I'm speaking to urge your support of Bill 593 to protect intersex children in Rhode Island.
Alistair, you're on with the Senate Health and Human Services Committee. Turn down your feed so we don't get that delay. Thanks.
Sorry, is this better?
Yes.
Wonderful. So I'm here on behalf of Interact, Advocates for Intersex Youth. I'm the legal director there, and I'm a proud Rhode Islander. We are the largest org in the U.S. dedicated to advocacy on behalf of the intersex community. And I'm here to urge your support because intersex people make up approximately 1.7% of the population. They're born with variations in physical sex characteristics, otherwise known as intersex traits, that are a perfectly natural and healthy part of bodily diversity. But this vibrant community has been forced to live in shame and secrecy after decades of non-consensual normalization surgeries performed by surgeons to ensure that intersex people did not grow up to become LGBTQ. These surgeries, including clitoral reductions, vaginoplasties, and sterilizing gonadectomies, continue today, and they should not occur in Rhode Island. While trans people have to fight for medical care they need and should be entitled to, intersex youth are fighting to be free from medical interventions that they never asked for. This is all because of a fear of non-normative bodies that should be left in the last century. We're so grateful to many in the physician community for making steps forward, but more must be done, and that's why I urge your support of Senate Bill 593, and I appreciate the time today. Thank you.
Any questions for this call? Thank you for calling in.
Thank you.
Yep. Next, I think we have Alexander Blitzer.
Hi. All right, I'll just hop right in. Chairman Miller and members of the Senate Committee on Health and Human Services. As someone who has never given birth, I may be an unlikely advocate for doula services. The only birth I've ever attended is my...
Alexandra, you started off so quickly I wasn't able to ask you if you're speaking on behalf of yourself or what organization you may represent. And we now know you're doing speaking on 484, so you don't have to answer that.
Yeah, 484.
Okay.
I'm a Planned Parenthood Generation Action intern.
Okay, thank you.
Yeah, thank you. So should I hop right in?
Go right in.
Amazing. As someone who has never given birth, I may be an unlikely advocate for doula services. The only birth I've ever attended is my own, and while I can't remember it, I can attest that it was difficult and traumatic. When I was born, I weighed 2 pounds, 11 ounces. My first 2 months were spent in an incubator at New York Hospital. My nutrients were administered through a central line, bacteria invaded my bloodstream and brain, causing sepsis, and I received numerous blood and platelet transfusions. I was constantly medicated, poked, prodded, and scanned. And I'm lucky. My parents are both physicians, which meant that I had 2 well-informed advocates by my side, making sure that I was receiving the best possible medical care. Most people don't have that kind of expertise on their side during the childbirth process, which is what makes doulas so important. A doula is a pregnant woman's advisor, a laboring mother's advocate, and a new parent's guide to taking care of a newborn. Without the invaluable advice of a doula, many women can suffer from preventable complications. Doulas help mitigate health disparities, and they are vital to fighting the crisis of maternal mortality. Numerous studies have shown that working with a doula leads to fewer birth complications, greater success with breastfeeding, and a decrease in the length of labor. And even more importantly, doulas are especially equipped to aid low-income and Black women, as they are uniquely capable of minimizing the impact of medical racism by recognizing biases and providing culturally sensitive, patient-centered advocacy. In a medical system where a woman's pain is taken less seriously than her male counterpart, we must mobilize against medical sexism and racism, and doulas are essential to this battle. Every woman and child in the state of Rhode Island deserves a trained advocate on their side before, during, and after childbirth, and that assistance must be available to all, regardless of their income. I implore you to vote for Bill 484 to ensure that every birthing individual in Rhode Island has access to a doula, regardless of whether or not they have the funds available. This is a vote against medical sexism and medical racism, and a vote for patient-centered advocacy that makes birthing people feel comfortable, supported, and heard. Thank you.
Any questions for this caller? Thank you for calling in.
Thank you.
I believe next we have Anthony Caldamone on the line. If you are speaking on behalf of another or yourself, please let us know, and which bill you wish to testify on.
Thank you for the opportunity to speak to oppose Bill number 593. My name is Anthony Caldamone, and I'm a pediatric urologist at Hasbro Children's Hospital and professor of surgery and pediatrics at Brown. Having the predominance of gray hairs in our group, I thought it helpful to give some perspective on the issue of disorders of sex development and gender identity. My training was based on the philosophy of John Money from Johns Hopkins. He was a leading psychosexual voice of the time. We were taught that gender identity is a social construct and therefore malleable up to a certain age, based on environmental factors. That is to say, the way parents choose to raise their child, how they dress them, or what toys they buy for them will determine their gender identity. We have learned since from patients, parents, patient advocacy groups as well, that philosophy was wrong, and that individuals born with genital anomalies are just that, individuals, and need to be treated individually, and that gender identity is a multifaceted construct. A major point of this bill is that these restricted surgeries would be limited and only prohibit a specific list of surgeries on children with variations of their physical sex characteristics. However, it's imperative to understand that as written, the scope of this bill is completely understated and will unintentionally affect children with no increased risk of gender identity issues. This bill is written would prohibit surgery to relocate the urethral opening for the flow of urine. The vast majority of these patients, both boys and girls, with this specific genital anomaly are not considered intersex and have no greater gender identity issues than that of the normal population. For instance, an abnormal urethral opening in a boy, a very common problem occurring in about 1% of all boys, we call hypospadias. And the consequences of restricting this surgery until the age of adolescence are very significant. These boys would be unable to stand to void, albeit not an issue with half of us here, I get that. But more importantly, these boys would have this surgical repair at an age when they have much more pain, require a catheter connected to a drainage bag for a couple of weeks, out of school and regular activities for a period of time. Compare the infant who has the same hypospadias repair, an outpatient procedure, barely uses a dose of Motrin postoperatively, and a catheter draining unnoticed into a diaper with full activities. More significantly, however, is that there is excellent medical evidence indicating that hypospadias surgery in adolescents is fraught with a higher complication rate, which translates to additional surgeries, each of which carries a progressively higher complication rate. There's also medical evidence telling us that adult men with uncorrected anatomical differences in their penises have difficulty with intercourse, are unhappy with their penile appearance, and have more mentally unhealthy days. Therefore, to presume that given the opportunity at adolescence to make the choice of surgery, that most of these children would choose not to have surgery has no basis. Now, one more point. Additionally, as written, this bill would also prohibit surgery for boys with an undescended testis, unless there's a cancer issue. The undescended testis has an incidence, again, of nearly 1%. The most consistent reason that we operate on undescended testis at a young age is to preserve testicular function, because all medical evidence indicates the longer a testis remains undescended, the greater the risk of functional loss. That is, the greater the risk of loss of fertility. In fact, we have evidence that there is a difference in the fertility potential of an undescended testis of a 6-year-old compared to that of even a 3-year-old. We must operate early on this problem. Prohibiting surgery for undescended testis would deny a chance to preserve future testicular function, including fertility, to approximately 150 boys per year in Rhode Island. So in conclusion, while the intent of this bill is to raise awareness and protect the young child born with genital abnormalities until that child is indeed can be part of that decision-making process, the effect is on a far larger population of children who have no increased risk of gender dysphoria compared to the normal population, and delaying their option for surgery presents significant added risk. Thank you very much for the opportunity to present.
So, doctor, you did say you were an MD, right?
I did.
Yeah, I'm sorry, because it wasn't listed on here, so I just wanted to clarify that. I'm looking at the legislation, and there is parts of the legislation that allow for exclusions like surgery to allow urine to exit the body, which I think it was part of your description on surgery that you think would be appropriate. And
Actually, it was not part of my description. What is described in the bill is if there's a blockage to the flow of urine, you will have the ability to correct that. What I was describing is a congenital anomaly where there's no blockage to the flow of urine, but the urine comes out in an abnormal location, sir.
Okay, so could that definition about urine exiting the body be amended to actually go towards your explanation of something you think is not covered by that?
I think that's only one factor that would need to be amended.
Yeah, and you gave, I believe, maybe 2 or 3 explanations. So those 2 or 3 explanations may or may not be covered by the existing language. Could the legislation be further amended to include those procedures which you think are should be excluded, like the part in Section 2 under number 3?
Right. So they would need to have a discussion as to what is exactly included and what is exactly excluded, because as the way it's written now, it does present some significant confusion to the medical community.
Yeah, but could it be less confusing? I mean, you're an MD. You're talking about 2 or 3 very specific procedures. So could those 2 or 3 very specific procedures cover your concern, and therefore with amendment language to the bill or sub-A language to the bill, could yours and other MDs who have concerns which may not be covered with the exclusion language under number 3 be amended to cover your concerns?
In the interest of time, I mentioned two.
Yeah.
That is the hypospadias and the undescended testis. There are others, and I know I've left that for others to testify this evening about other similar concerns that we have, sir.
Okay, but how long a list would that be? Is that something that could fit within legislation?
I think it's a list that would have to be pulled apart individually, and each case would have to be discussed in order to be able to come up with a compromise on some of these issues.
Okay, thank you.
Thank you.
Senator Bell, I believe, has a question also on this issue or this legislation.
Yes. Thank you, Chairman, and thank you, Doctor, for your testimony. I do very strongly support the intent of this legislation. However, it's my belief from reading this that there was a rather serious drafting error made by Legislative Counsel. As I read this legislation defines a definition that is intended to refer and narrow it to only intersex individuals. However, that definition is not actually included in the rest of the law. That definition is written in the definition section, but not later used, and not used to limit this to only referring to intersex surgeries on intersex individuals. So my question for you, Doctor, is whether you would support the legislation were it refined to only relate to surgeries on intersex individuals and only using the definition, or I guess only on individuals using the definition listed in the bill of individuals born with variations in their physical sex characteristics, and whether it were limited to only those individuals and only surgeries designed to impose a particular gender identity?
Well, I think that's a complicated question, quite honestly. My initial reaction would be probably not, because I would have to see what the definition of intersex is, what it includes and what it excludes, and what the type of surgeries are exactly. It was mentioned by the senator that there are two institutions that have developed policies against the surgery. Those surgeries are extremely specific and specifically designed, and they're nuanced very, very well. They're not broad generalizations, which is what this bill is.
So, through the chair, if I may, it sounds like your suggestion, Doctor, is that this legislation should be rewritten to specifically ban those enumerated, those specific surgeries, rather than describing a broader class of surgeries. And would you support the legislation if it were written so that it bans a set of specific surgeries that are designed to impose a particular gender identity on intersex individuals?
I probably would not. And the reason I would not, because that would take that decision away from the parents. And the parents have to be part of this decision process. And that would completely marginalize the parents in making this decision. Parents make decisions about all sorts of medical care, don't they, every day? And this is another one of those decisions that they have to make. And it should be well-informed parents from a multidisciplinary team to help make this decision possible for this child.
Okay. Thank you so much, Doctor.
You're welcome. Thank you.
Other questions for the doctor? I'm going to try to continue the testimony on 593 rather than going the democratic way, which we've been doing on this. It seems to be consistent that we'll get some of the same questions, and so I want to see if that's the case. So I'm going to try to cover 593 first, based on the conversation we just had, to see if the comments are consistent one way or another on that. So the next person we're going to try to contact is Bria Brown King. That is? Okay. Next person we're going to try to contact on 593 would be Casey Poor. Is this Casey?
Yes, hello.
Thank you for calling into Health and Human Services. You're on the call with the committee. Just please indicate, we believe you want to testify on 593, whether you're speaking on the side of your, on behalf of yourself, or whether you're affiliated with an organization you wish to identify.
I'm speaking on behalf of myself.
Okay. Go right ahead.
Okay, thank you. Yeah, I mean, I just wanted to call. I helped write the letter of support and sent it out to a lot of physicians who are very eager to help out. And I guess I just wanted to see if anyone had any questions about the... I'm sorry, what?
I'm sorry. Go right ahead.
Okay. And I just wanted to see if any legislators had any questions about the citations or scientific material that was presented. I'm happy to talk with anyone about, you know, any concerns or lingering questions they have about the basic research. And I also wanted to state that although in the letter I didn't mention, you know, the issues of hypospadias and repairs for masculinizing surgeries, that these are additionally can be very harmful for individuals. An individual actually talked to me about an experience, content warning for medical violence, that she had actually today, where she saw a 3-year-old, you know, screaming, crying in pain, saying, "Please don't bring me back into the OR. I don't want this," you know, showing clear lack of consent and assent, screaming and being held down and having, you know, a mask of anesthesia put over his face against his will. And I'm not going to mention the institution because I don't think it's... I think it's better for better for my colleague if I don't. And in a subsequent, or rather in another testimony that was provided by intersex individuals, an individual spoke at Fenway Health during the sexual and gender minority conference of, you know, fostering excellence among medical providers. And this individual actually stated that they have memories as young as 3 and 4 years old of being very uncomfortable with the medical care that they were receiving and being very scared of going into the hospital. So I just wanted to say 2 things, that although masculinizing operations were not mentioned in the letter, I absolutely support banning, you know, these harmful surgeries on individuals assigned male at birth. And I also wanted to say that although they're being done at a young age, 3 or 4, that people actually still have memories of it. And that's not even to mention the adverse effects of anesthesia for the developing brain that the FDA actually sent a warning for in 2016. So I just wanted to include those little pieces of information since I don't think they were represented in the letter, and answer any questions that folks may have. Thank you so much for your time.
Any questions from the committee? Thank you for calling in.
Absolutely. Thank you so much.
Senator Bell, did you want to respond to anything?
Yes, thank you so much, Mr. Chairman, and thank you for your testimony. I strongly support the intent here. I really do think, some of the traumatic stories that we've all read about intersex individuals being having surgeries forced on them to determine their gender identity, often getting it wrong. It's very traumatic, and I think it's important that we find a way to craft legislation to address this problem. I'm wondering if you have any thoughts on the specific way that this should be addressed legislatively, and if there are any suggestions you have about how we can clearly identify the surgeries that we most want to prevent, and how best to tailor the language to make sure we're targeting the specific surgeries that we need to make sure to prevent.
Thank you so much for asking. I, read over the bill a few times, and I actually think all of the surgeries that were indicated are exactly the types of surgeries that, we need banned. And those are very concrete examples of surgeries that are represented in the medical literature and, will be listed, for example, on like a surgery board if someone was doing a vaginoplasty. So I think I'll defer to the legal experts on that question. But I myself felt from a medical research standpoint that the listed surgeries were adequate in order to prevent unnecessary medical harm for minors.
Thank you so much.
Absolutely.
Any other questions for Emily? Thank you.
Yeah, absolutely. Have a good day.
Yep. Okay, now we have Emily on the line. I'm sorry, I referred to the next person. Emily Quinn?
Yes.
Is that who we have on the line? Sorry to misidentify you earlier as the person who spoke, but go right ahead and just indicate whether you're speaking on behalf of yourself or another organization you wish to identify.
Sure. My name is Emily Quinn. I'm a Providence resident speaking on behalf of myself.
Okay.
And I can just go from here?
Yep.
Wonderful. I am a 30-year-old intersex woman here in Providence, and I found out I was intersex when I was 10 years old, and doctors told me that I would have to have surgery unless or otherwise I would get cancer. So I went to and saw a lot of different doctors about the potential for getting cancer and if I should have surgery. And I never really got conclusive results, and it wasn't until about 10 or 12 years later that I met a group of hundreds of other intersex people who all had been told similar things. And fortunately, I didn't go through with the surgery, but a lot of them did and had a lot of issues that arose from it, especially because they weren't fully informed about the procedure beforehand. And then a couple years ago, my nephew was born with hypospadias, but the doctors told us that rather than telling us they had hypospadias, they tried to tell us that he was cut on his penis during the birthing process. And it was just really lucky that I was in the room because I didn't understand and tried to get more information out of them. And they eventually confirmed it was hypospadias, but I was the one who had to bring it up. So I think a lot of people just assume that it doesn't happen still today, but that was just a couple of years ago. And this sort of thing happens all over the world and to really young people who don't have the ability to consent and often don't understand the full implications of any of these procedures. So I am in support of the bill to be passed. Thank you.
So I just want everybody to understand specifically your personal experience and then the experience of somebody else that you described. Your personal experience, if I got this correct, is that you were proposed to have surgery when you were 10 and you are how old now?
No, I'm 30.
You're 30 now, okay,
Yeah, I was pressured often.
okay. Any other questions for Emily? Thank you for calling in and sharing your personal story.
Thank you.
Yep. I believe we have on the line Ethan Huckle. Is that right?
Yes.
Okay, Ethan, just if you are speaking on behalf of yourself or another organization you wish to identify, please do so.
Thank you, Chair Miller and members of the committee. My name is Ethan Huckle. I am the board president of TGI Network of Rhode Island, a nonprofit that serves the state's transgender, gender diverse, and intersex community. And we are in strong support of Bill 593, which will protect intersex children from invasive medical procedures. The primary goal of these procedures, which take place in approximately 1 of every 2,000 births, is to establish for an infant the appearance of genitals that fit a particular gender stereotype, based not on that patient's personal goals, but on the assumptions of others. While the underlying motivation may be a desire to remove social obstacles and emotional stress, they carry with them significant risks, including sterilization, chronic pain, nerve loss, incontinence, and incorrect sex assignment. And I think we can all agree that any of these side effects comes with any of these side effects comes the potential for even greater stress. They're all impediments to an individual's physical and emotional health. And what I heard earlier with the pediatrician who called in to testify was that he was essentially comfortable sacrificing the well-being of intersex kids because he was making the assumption that there were fewer intersex kids and that more often this wasn't, there were fewer people who were going to later deal with these side effects. And simply that's just not reflected in research. So I hope that you and the committee support Bill number 593, and thank you very much for considering our testimony.
So Ethan, part of our conversation with Dr. Caldemone was around whether we could further identify procedures that he discussed, because there are several procedures identified in the legislation, and should that be expanded? Any thoughts around that?
Well, so I'm not a medical professional, and I will defer to medical professionals, but I will say this. What I heard in his testimony was an unwillingness to even dig into the details for the benefit of intersex kids. So what he was saying was, well, when it comes down to it, no matter what we look into the bill, I'm not going to support this because it takes the decision out of the hands of parents. And quite frankly, that's not entirely true. Parents are a part of their child's life beyond just those first weeks after birth, right? They're going to be a part of that conversation moving forward. But what this bill does, is allows that child a chance to know and consent to procedures that they are going to have and that they're going to deal with for the rest of their lives. Certainly not taking it out of the hands of parents entirely. I wouldn't imagine that a parent would have no voice in the decision of a 12-year-old or someone in their teens, but the child deserves to have some voice in that as well, right? It is their life. So I felt like that pediatrician's testimony felt really disingenuous to me, because there were opportunities there to offer expertise to make the bill better, and his choice was to say, no matter what happens to this bill, I can't support it.
Yeah, we're able to understand the nuances of his testimony, but we're also, to make the legislation accurate to whether there's concerns more widespread and justified in the medical community, whether there is an actual credible case for identifying other procedures in here that would be totally medically appropriate to identify.
Yeah, and like I said, I have to defer to medical professionals, but I would defer to those who make it clear that they have an interest in protecting intersex kids. and then enter into that discussion for details in good faith. That's
Yes.
my only perspective on
Yeah,
that. Yep.
I think the committee is only interested in good faith.
Yes, thank you.
And I think it wouldn't surprise you that Senator Bell has a question.
Okay.
Yes, thank you so much, Mr. Chairman, and I do apologize to you for asking so many questions. I think it's very important legislation. It's very important we get it right. I just wanted to say, first of all, thank you, Ethan, for all you do for the community. It's very deeply appreciated across our state. And I do strongly agree with your characterization of the doctor's testimony. I was alarmed about some of the comments about giving parents choice. I think it's important that we understand that sometimes intersex identity choices are not always valued, and it can be very damaging in the future to intersex individuals when these surgeries are performed too early for them to make the decision themselves, which is why this legislation is so important. One of the questions I had for you was, in your view, is it often the case that the medical, one of the things I noticed about the legislation is that the way it is written, the liability is limited towards the medical professional, and does not include the corporation. And one of my questions was, in your experience, are there corporations that, or particular hospitals that try and push some of these surgeries, or are there particular corporate entities that also are involved with the prioritization of these surgeries? I'm wondering whether it would make sense to make the medical, not just the liability, not just on the provider, and also hold the provider corporation joint and severally liable. In your experience, are there particular hospitals that might push this kind of surgery?
Thank you, Senator Bell. I wish that I had the answer for you. I'd have to defer to the folks at Interact who work to draft this bill, and to others in this community. I honestly, I think that my gut says yes, but I can't speak to it, so I just have to defer to others on that. Sorry.
Thank you so much.
Yep.
Any other questions for Ethan? Thank you for calling in.
Thank you.
I think next we're going to retry Bria Browning King. Bria?
Yes.
You're on with the Health and Human Services Committee. Just please indicate whether you're speaking on behalf of yourself or another organization that you wish to identify.
I am calling on behalf of myself in strong support of SB 593. I am a person living with congenital adrenal hyperplasia. It hurts to know that so many people in my own community don't understand why this bill is so important. I see this bill as a step in the right direction. I think it represents futures where children get to be a part of the conversations that's typically happening around them and oftentimes without them. And I think it represents a future where we stop telling children that they don't get the right to have a choice about what happens to their bodies. When I listen to parents who are in opposition of this bill, I hear a lot of fear, because I think that they're terrified of raising children whose bodies are different than what's considered to be normal. I had a parent last week tell me that I'm asking people to give up their womanhood by supporting this bill, because there's still people in this society who believe that womanhood is still defined by a woman's ability to have penetrative sex with a man and have babies. And I believe that our bodies should belong to us. We should have the right to decide what body parts we want to have, how we want those body parts to function. And I don't think that parents and doctors get to make those assumptions about what we would and wouldn't want to have done to our bodies. These procedures are cosmetic, and we should be instead of forcing kids to undergo these very complicated and risky surgeries, we should be putting more emphasis on normalizing having bodies that are different. And the bill isn't banning surgeries, it's delaying them. So if when a kid turns 12 and they want to have this conversation with their parents about surgery, then they'd be able to do that. I don't think that this is an unreasonable ask. It's actually a compromise, because if you ask me personally, we can't have conversations like this without talking about the other systemic issues like patriarchy, misogyny, transphobia, and all of those other things that force bodies into these boxes that they don't belong in. So I'm speaking from the CEH perspective in strong support of this bill. I think that there's this need and almost this obsession with controlling women's bodies, and I think that this bill is a step in the right direction to end that.
Any questions for Bria? I want to thank you for calling in and sharing your personal thoughts on the bill.
Thank you.
Yeah.
Okay.
Siang Wu?
Yes.
Go right ahead with your testimony, and let us know if you're speaking on behalf of yourself or another organization you wish to identify.
Thank you. I'm speaking on behalf of myself. I'm a physician, and I'm the current director of pediatric urology at Hasbro Children's Hospital. I'm speaking to oppose this bill because it has unintended consequences of preventing us from delivering care to a separate group of children who do not have intersex and who do not have increased risk of problems with gender identity. The definition of variations in physical sex characteristics in this bill is so broad that it includes any patient with an isolated genital problem. Now, although some would quote that 1.8% of the population has intersex, the most common intersex condition, which is congenital adrenal hyperplasia, occurs in 0.01% of children, which is 100 times lower than the quoted 1.8%. And this lower number is borne out in our experience here at Hasbro Children's Hospital, where we have carried out 0 surgeries for intersex patients over the past 5 years. One of the prohibited surgeries in this bill is any procedure that lengthens or reroutes a urethra from its native orifice. And as you heard from Dr. Caldemone, the most common surgery that we perform is a hypospadias repair. And these are usually done at 6 to 18 months of life precisely to decrease the trauma to the child. And it does happen in 1% of males. We carry out about 100 hypospadias procedures per year at Hasbro Children's Hospital. Boys with isolated hypospadias are not intersex, and they do not have a higher rate of gender identity problems. The reasons we recommend hypospadias surgery are to improve fertility and sexual function, in addition to creating a normal urine stream. These procedures are not emergent, and they don't fall into the treatment exceptions of incontinence, infection, or cancer risk, but they are medically necessary. We also take care of children with more complicated and rare conditions with abnormally positioned urethras, such as bladder exstrophy or cloaca, which this bill would prevent us from repairing. And again, these patients are not intersex patients. This bill would put the medical board in the position of having to decide if a physician who performs a non-emergent but medically necessary genital surgery in a child would be disciplined. I estimate that it would severely limit our care of at least 250 children per year in Rhode Island, and the unintended consequences of this bill are significant. Thank you again for the opportunity to testify.
So I did strive to have Dr. Caldemone identify a procedure, and you did seem to do a better job of defining the procedure that was of concern to you. Are there other procedures that are of concern to you?
Yes, the hypospadias is the major one. The other group we need to listen to are the adult congenital adrenal hyperplasia patients who've had surgery and to hear their perspective on vaginoplasty and urethroplasty. The literature suggests that women who've had them done in adulthood are not that happy with their outcome.
So I'm looking at the legislation, and some of this is at least attempted to be clarified on page 1, lines 6 through 8. Do you think that further use of that or extension of that attempt to clarify what you have discussed could be done in that part of the legislation?
Yes, I think we need to narrow the description of the individuals covered here to narrow them down to intersex. Right now it's a very broad description, and a better delineation of what the prohibited surgeries would be helpful too.
Thank you. Any other questions? Senator Bell.
Thank you so much, Chairman. I'm going to ask you the same question I asked the previous doctor. Would you support the legislation if it were narrowed to only relate to intersex individuals and only surgeries designed to impose a particular gender identity?
I would certainly want to read the bill and see what the exact results were. I think I would have a much easier time supporting such a bill with specific delineation of conditions and surgeries than it exists currently.
Thank you.
Any other questions for Dr. Wu? Thank you for calling in.
Thank you.
I believe we have Liza Aguiar on the line.
Yes.
Please identify whether you represent an organization or you're speaking on behalf of yourself, and go right ahead.
I'm representing myself and the Society of Pediatric Urology. I'm speaking to oppose the bill number 593. My name is Liza Aguiar. I am a pediatric urologist with Brown Urology and an assistant professor of surgery and pediatrics at Brown Medical School. Thank you for allowing me to speak today. I'd like to start by telling a patient's story. I'll call her Ava to protect her privacy. Ava was born last year with a persistent cloaca, which is a condition where the urethra, the vagina, and the rectum all empty into one common channel instead of 3 separate openings. Ava's genetic sex is female. Her outer genitalia are female. This was not a case of sexual ambiguity. I'd like to stress that most of the patients that would be affected by this bill, like Ava, do not have intersex diagnoses. We, as pediatric surgeons, do not perform surgery to confirm gender identity. Our goal is to simply preserve and maintain function. Back to Ava. As you can imagine, Ava's parents were worried and concerned not just about Ava's anatomy, but about her future health, ability to have intercourse should she ever choose to, her fertility, even her future psychological health. The counseling prior to surgery was extensive and multidisciplinary, and after careful consideration, her parents decided that surgery was the best option. I recently performed surgery on Ava to separate and move her urethra and vagina, and the pediatric general surgeons created an anus for her. She was in the hospital for 2 days, and fortunately, she has recovered and healed very nicely. Ava's surgery was not to address an immediate risk. So if this bill were enacted, it would have resulted in disciplinary action against me. As a physician, I am not for nor against surgery. I am for advocating that all treatment options be available for children, including surgery when appropriate. I am for maintaining the individuality of patient care and allowing parents to make the best decisions for their children with appropriate counseling on all options. Fortunately, we have a multidisciplinary approach at our institution, which includes specialists from many different areas of medicine, including mental health. This allows for discussions of all options and encourages individualized care. The American Medical Association Council on Ethical and Judicial Affairs spent 2 years evaluating how we approach genital surgery. They carefully considered all sides and perspectives, and their conclusion was that parents should be the ones to make medical decisions on behalf of their children. We follow the same ethical principles for any other procedure on a child. Our opinion is that medical procedures should not be legislated, and it should be a decision between families and the physician team, and patients when appropriate. My hope is that I have conveyed the complex nature of these patients and the highly individualized care these patients need and deserve. I recognize and appreciate this bill was written with good intentions, but the reality is that it will limit patient care for hundreds of patients in Rhode Island per year. Thank you for the opportunity to speak.
So we just finished with Dr. Wu, and I don't know if you heard any of that before you talked.
Yes, I did.
So my questioning would be consistent with what I talked to him about, which was your example was a very specific procedure, and he seemed to have his example a very specific or similar procedure. Would it change your position on this type of legislation if the sponsor or the committee had any input on changing the language around what kind of exceptions that I actually referenced in the bill to what kind of procedures would or would not be defined under this legislation?
I think I'll echo what Dr. Caldemon and Dr. Wu have mentioned. Our concern is that every single patient is so different, and to create legislation that applies to such individual cases is very difficult, and I worry about that.
Yeah.
I also think that the idea that there is no harm in delaying surgery is simply not true. I know we will be hearing from a CAH patient and her point of view on delaying surgery, but the fact is clear, there is clear evidence within the intersex community, although there are two sides, but very clear in our literature that those who have delayed surgery can regret it, families and patients, specifically in the congenital adrenal hyperplasia patient population. There are patients and families who regret any surgery, but I think that we have to listen to the majority of patients in this situation.
So if I was to again reference Dr. Wu's testimony, he testified that to his memory, they had no patients that they did the type of surgery in which this legislation was intended to prohibit.
Yes,
his experience.
Exactly.
So if the legislation got more specific to the type of surgery that this legislation intends to prohibit, and was further defined, so the type of surgery that both you and he discussed was allowed under this legislation, would that change your advocacy around this legislation?
Let me just give some background. I think the reason why we have not done a surgery in 5 years is not just because we, this intersex diagnoses are extremely rare, but because we do it right here at Brown. You know, pediatric urology is a young specialty. It was formally identified in 2007. The first guideline document on intersex was published in 2006. We are well aware that anyone older than 12 may have been treated before modern management and before we standardized our care. But I can tell you that as a Brown medical student graduate, as a Brown residency graduate, we are doing it right here. We have a multidisciplinary approach, and our parents do feel supported in making the right decisions. And again, I hesitate to apply legislature to the physician-patient relationship because every single one of my patients is so unique, and it's difficult for me to imagine a law to limit the discussion that I have with my patients.
But if the legislation was drafted in such a way that it was consistent with the medical guidance on it, that would be at least an endeavor that you might want to examine.
I would absolutely consider it, yes.
Yeah, okay, thank you. Any other questions? Senator Calkin has a question for you.
Thank you, Mr. Chair. And I wanted to follow up on your questioning. So you said the relationship between you and your patients. Are you considering the parents the patients or the child the patient?
You know, my first priority is the child. And I think that the parents obviously make the decision for the child in all situations, including the type of surgery that I perform. And I'm fortunate to have had very positive experiences with my families and with this institution. So I'm not hesitant to say that, you know, we approach these diagnoses correctly and that we would, you know, yeah, go ahead.
I guess my specific question is regarding intersex general assignment. If this bill just tackled that, would you be in favor of allowing the child to make that decision when they are ready, rather than letting the parents make that decision for them?
Again, our standard of care is not to assign a gender identity, not to sex-affirm surgery and to perform sex-affirming surgery at 6 months of age. Our goal is simply to preserve and maintain function and buy time. That's it. And that is why we have not had any surgery, intersex surgery in the last 5 years. This is standard of care for this institution.
Okay, thank you.
Any other questions for Dr. Aguiar? I want to thank you for calling in.
Thank you.
Yep. So I believe our next caller is Patience Crozier. Patience, are you on the line?
I am.
So
My name is Patience. Oh.
Go right ahead, and you can, just before you start testifying on this legislation, can you just let us know if you are speaking on behalf of yourself or another organization that you wish to identify?
Absolutely. My name is Patience Crozier, and I'm testifying on behalf of GLBTQ legal advocates and defenders. So thank you, Chair Miller and committee members, and thank you so much for the opportunity to testify in support of S593, the Rhode Island Intersex Youth Protection Act. GLAD is proud to support this bill. I think this is an important human rights measure that protects intersex children. I think the bill is tailored to stop unnecessary genital surgeries performed on intersex children under the age of 12. and that these listed surgeries can leave survivors harmed emotionally and physically for their entire lives. I think the medical establishment is starting to move to realize these harms. These practices are condemned by the World Health Organization, by the American Academy of Family Physicians, and I think Rhode Island should act to protect these children. And intersex children, I think as so many have spoken tonight, are born with variations in their sex characteristics, are part of the wonderful natural diversity of the human experience. They're not medical problems to be fixed. And I think the LGBTQ plus community knows well that our community should affirm and celebrate this diversity. And first and foremost, to really listen to and center the voices of intersex people like Emily and Brianna, who shared their perspectives today. And I just want to thank them for that. So GLAD hopes this bill will receive a favorable vote out of committee. And thank you very much.
So I've worked with GLAD on the past on several pieces of legislation, most notably marriage equality. And the expertise is admirable within the organization and very useful for legislators. And I wondered if you had listened to those who are practicing urologists, and especially pediatric urologists, and whether a little bit more work on definitions of what was appropriate surgery and what was not appropriate surgery should be considered to be included as part of the legislation.
Well, thank you so much. And I know GLAD has really valued working with the legislature on so many important bills, and the Uniform Parentage Act, comes to mind from last year, which was, again, I think really centering children and seeking to protect children. I think that, first and foremost, the medical community should really, it should really be centering the intersex adults who have experienced these surgeries and learning from them. And I really hope that in this process, the medical community can engage with the intersex community really thoughtfully and deeply, and really open their hearts and listen to those voices, and, be open to amendments that can be a compromise. And I think also, as Brianna said, that this bill is already a compromise, right? Not prohibiting these surgeries, but trying to delay them to allow children a chance to really participate meaningfully in those decisions. Parents the time to kind of step away from that, immediate moment in that vulnerable time when children are so young, right? And, parents can often barely sleep through the night, right? And really have that time and that perspective to make decisions that are really centering, medical necessity and best practice, and as opposed to, decisions that might be focused instead on, fears and, desire to fit a child into a particular gender norm in any event. So my hope is we can find some compromise, and that the medical community will be open to that, and really engage deeply with intersex advocates and intersex people. And obviously we're happy to participate in that process. Although I would defer to Al Idelson, who I think is really kind of the leading expert on this issue, and I think knows the medical research really well.
So, they were pretty consistent on at least one or two procedures that they thought could help as a compromise. Have you encountered that, especially from a group of doctors who said they haven't done what was the intent of the legislation, that type of surgery, since their medical guidance had advised against it? So I was wondering, in your advocacy, if you've done so in other states, evolved into including the procedures that were identified by the pediatric urologists who've testified.
Well, I think the issue of hypospadias is one that I have heard come up. But I think, again, Rhode Island is the first state in New England where I've engaged in this advocacy. So I will admit to myself to being new to the medical procedures. I have heard of the issues with hypospadias, but I think, again, that people like Al Idelson and folks who are leaders in the intersex community can really speak to that issue directly. And I would hope, I don't know if we can invite Al back up to speak to the research on that issue, but again, I think that there is a response, but unfortunately, I'm not the best person to give it.
Okay.
I'm happy to look into that issue and provide further information to the committee as a part of this process, and I'm happy to do that.
Yeah. GLAD's input has been so positive in the past that we would look forward to that input going forward on this legislation.
Wonderful.
Thanks. Any questions for Ms. Crozier? Thank you for calling in.
Thank you so much.
I believe we have Dr. Philip Capuzzo on the line with us at this point.
Yeah, speaking.
Yep. Go right ahead and just identify whether you're speaking on behalf of yourself or anybody else or organization.
I'm speaking on behalf of myself.
Okay.
And thanks for this opportunity to address the committee. I'm a pediatric endocrinologist, board certified in 1984, and I continue to the present as a member of the faculty at Brown as a professor of pediatrics. I'm going to start off by saying that there's a personal irony for all of this for me, and it pains me to be speaking in opposition to the bill. I've been an advocate for children with disorders of sex development, battling many of my pediatric endocrine colleagues since the late 1990s to end the climate of shame that was imposed on so many children and adults with intersex disorders. I was a founding member of the advisory board of the Intersex Society of North America, and for many years, I served as a pro bono consultant for Lambda Legal, an organization that provides legal services to intersex patients. I've published on the surgical management of intersex disorders, and I was the representative pediatric endocrinologist on a panel at the Hastings Center in 2002, an internationally recognized think tank. The subject of the panel was appearance-altering surgery for children, and the conclusion of the conference was that appearance-altering surgery for purposes relating to gender identity should not be carried out on children prior to the age of assent. And I was very involved in drafting the output from that conference. The surgical procedures that were our focus of that conference were actually many of the, quote, prohibited surgeries described in the bill. So why am I speaking in opposition to the bill? There are two factors. First of all, I agree with my pediatric endocrinology and urology colleagues that the bill may have unintended consequences. And honestly, if it's going to be enacted, I hope that it will be much, much more carefully drafted than the bill as it currently exists. Another specific issue that I'd like to see addressed is the age of 12 that's cited in the bill. I've encountered many children with intersex disorders who've reached the age of assent prior to the age of 12 and have been very much in favor of directing their own care. My second reason for opposition to the bill, and I feel like I'm going out on a bit of a limb here, is one that's much broader in scope, and it could not be addressed by amendments to the bill. This bill aims to legislate the specifics of care provided by a physician in consultation with a patient, and in the case of pediatrics, with the patient's parents. In recent years, the U.S. has seen efforts to legislate the interactions between patients and caregivers that relate to, for example, gun safety and giving advice on gun safety, women's reproductive health, obviously, and most recently, transgender medical care. Just as this bill aims to prohibit surgeries that are harmful to children with intersex disorders, there are bills emerging in states other than Rhode Island that aim to ban surgery for transgender individuals. I don't know how to resolve this. All I can say is that the situation in Rhode Island has changed dramatically, and without being self-aggrandizing, I'll just state that I'm a major reason for that change. When I became involved in this area in the late 1990s, surgery that was meant to support an arbitrary gender assignment was the norm. It is now the norm to not do such surgery. And I worry about all of the implications of a bill aimed at dictating an approach to medical care when what I think is really needed is just continued vigorous advocacy activism where appropriate, legal means. So I'll stop there rather than taking up more of your time. But I think I've made the point that I am in support of much of what's been said, nearly all that's been said by the proponents of the bill regarding principles relating to the care of children, but I have serious concerns about the bill.
So let me just clarify your position on this. Are you saying that, and this is might be an attempt at a large generalization, but are you saying that this has evolved since you've been involved in it in 1990, whatever, to around 2005, because that's a date that was referenced, that where this type of surgery based on medical guidance within the practice, that at least in Rhode Island, surgery like this no longer...
It has evolved tremendously.
Yeah.
So
my only concern with that self-governance and guidance is that without legislation, what's to prevent that guidance from changing in the future? And is that worth the risk?
Well, I think the answer to that is the function of medical societies, licensure boards, patient advocacy groups, the media. I mean, this entire area came to light the way it did because of the work of a journalist, John Colapinto, who debunked John Money's postulate in the early 2000s. So I think that there are lots of things that have led to the changes that have occurred already and would prevent backsliding. And, you know, I feel fortunate to live in a part of the country where attitudes about this sort of thing are...
Rather than just relying on medical guidance from within the medical, societies that govern around this, is there legislation, or do you think there could be legislation more carefully crafted that could keep us from backsliding, as the language you use?
I think the answer to that might be yes, but if I can be so bold as to ask a question, is there another example? I was unable to find another example of legislation that would ban specific surgical procedures. So, for example, the performing a vasectomy without consent is not that doesn't happen because of legislation that would ban it. It doesn't happen because it's unacceptable at so many levels. I mean, medical licensure boards matter. I simply can't think of another example where legislation has been the path to ending a harmful medical practice, especially one involving surgery.
Yeah, I totally respect your position on the issue and the work that you've done. I'm just concerned that we were presented with legislation models from other states, however long ago it was we started hearing this testimony. But so I think
all pertaining to this issue, though.
Yeah, I think we need to further pursue whether we can get there. I think just because we're not there doesn't mean we can't get there.
Well, all I'll say is that I hope that if there is going to be a path to getting there, I hope that there'll be a variety of individuals, including medical ethicists, who are involved in the process. It shouldn't just be. It should go beyond activists, advocates, physicians.
Yeah.
I just see this as a huge step, and what's to say that somebody isn't going to introduce a bill to ban surgery for transgender individuals?
I agree, and that's why I think it's at least worth pursuing with the sponsor and other advocates, including yourself, on whether there is a point where language could work as legislation rather than medical guidance.
Yeah.
Yeah. Thank you. If there are no other go out, Senator Bell has the hand up.
Yes, thank you, Chairman. Just quickly, I want to echo the Chairman's comments about the importance of the underlying issues here. I do want to. I have to say, I was bothered by your comments, Doctor, drawing an equivalence between this legislation and a ban on transgender surgery. I do think we have the ability to separate out what kind of practice procedures we're going to ban, and just because banning good procedures would be a bad idea, it doesn't mean that there are no procedures that should be banned. There's a long history of medical procedures that have been done that have been harmful to patients, and there are many examples that we don't allow. And
that are not allowed based on legislation?
It is my belief that things like bloodletting are not allowed. And,
I don't think that that's true.
Okay. But I do think that their history, there were cases where many patients with mental illness received lobotomies that were not helpful to their care. I mean, there's been a large history of.
Can we keep this not only through the chair, but to the legislation? I know we kind of opened up a very large window here, but I do want to go on to the other calls if we could. I think we've approached this in many angles. So, are there any other questions for Dr. Gruposo? Thank you for calling in. It's very useful. Sylvan Fraser, I think you're on the line with the committee.
Oh, hello?
Yes, Sylvan?
Yes, that's me.
You're on with the committee. Could you please just identify whether you're speaking on behalf of yourself or another organization you wish to identify?
Yes, hi. I'm Sylvan Fraser. I'm speaking on behalf of Interact Advocates for Intersex Youth today. I'm the senior staff attorney at that organization. Thank you so much for giving us your time and attention today. I am going to start off by saying S593 is a critical human rights bill to safeguard the ability of individuals born with variations in their physical sex characteristics to participate in decisions that alter the most intimate parts of their bodies and affect their reproductive and sexual function, as well as
Sylvan,
their
can you slow down a little bit?
Sure. I'm sorry.
Thanks.
I'm a little excited after
I
hearing all of these points that have come up that I also want to make sure that I have time to respond to.
Yeah, I'm not putting a time limit as long as everybody understands we don't need several pages of written testimony rephrased in call-in testimony.
Sure. That makes sense. Thank you. So the points that I do want to respond to from physicians that we've heard testify in opposition today include, today we've heard from a doctor claiming that they're not doing surgeries that would be covered by this bill, and then explaining performing a vaginoplasty on a child under 1 year old. We've heard a doctor claiming to be a patient advocate, but then calling this community disordered. And we've heard a doctor state that he supports this community, but then claiming that parents should still be the ones to make these life-altering decisions for their children, even when there's no medically urgent reason to do so, when there's no reason that the decisions about the procedures could not safely be delayed until the individual is able to participate in the decisions for themselves. You also heard specifically from a pediatric urologist who objected to including individuals with a, quote, isolated genital problem in the bill, And I want to address why this is a misleading position that's intended to exempt the vast majority of children who are at risk for these procedures being performed on them in infancy. The procedures that doctor had spoken about to modify already functioning urethras on children with hypospadias have tremendously high complication rates, up to 50 to 70%, as reported in medical literature. That specifically was a multi-study review by Dr. Douglas Canning that I believe the pediatric urologists who have testified in opposition should be familiar with. This doctor, I believe this was Dr. Wu, also mentioned the notion that these surgeries are done early to prevent trauma to the patients. But I want to point out that if the surgeries are this potentially traumatic, that is all the more reason why the decisions really must be delayed until the individual can be the one to weigh in on whether those risks of psychological trauma as well as physical trauma to their bodies from the surgery are risks that they want to take on in service of the potential benefits, which are largely unproven and assumed to be, the benefits are assumed to exist based on assumptions about how individuals will prefer their bodies to look and function that are not going to be accurate to everyone's individual experience and priorities. Operating preemptively only increases the risk of needless preventable harm, such as physical complications, including sterilization, permanent loss of sexual function, urinary incontinence, nerve damage, chronic pain. Many issues are documented to result from the performance of these surgeries in infancy when they usually are performed. The most common age of operation is between 0 and 2 years old. And this all holds for hypospadias procedures as well as vaginoplasties and clitoral reductions on patients with congenital adrenal hyperplasia and other diagnoses that might put someone at risk for so-called feminizing genitoplasties, which several of the doctors testifying in opposition have also referred to. Surgeries that are covered by S593 are not emergent, as Dr. Wu also admitted. They are done based on assumptions and stereotypical notions about male and female bodies and the individuals who possess these bodies, who may or may not identify as males or females accordingly themselves. So it is disingenuous to say that these are not sex assignment surgeries under those circumstances. If an individual is being subjected to a surgery to enable them to urinate standing up, because that's a stereotype that we associate with males and male bodies, but then that individual grows up to identify as something other than male, it's really difficult to see how that would not be a sex assignment surgery. And likewise for an individual who undergoes a clitoral reduction in infancy in order to be given a smaller appearing clitoris that appears more feminine when that individual later grows up not to identify as a woman. And it is worth noting, too, that even if an individual grows up to identify with the gender or sex assignment that was surgically enforced on them in infancy, that doesn't mean that the procedure is necessarily any less harmful to their well-being. The physical and psychological consequences, aside from incorrect gender assignment, can still absolutely result and do result for individuals in those situations as well. And I also want to note that in situations where there is no urgent risk of physical harm to the individual that would require surgery, surgery that happens earlier than it needs to is it's a roll of the dice. I mean, there's going to be individuals who grow up who want to never have had the surgery performed, and they will never have the opportunity to go back and have their bodies intact. It's creating a needless risk of harm to operate preemptively. And I had one other point that I think is important to make, shuffling through my notes. Yeah, it was brought up, I think, just by the last speaker who called in, the notion that there aren't laws that prohibit specific medical procedures is not accurate. There are laws, including in Rhode Island, that prohibit female genital cutting specifically, as well as conversion therapy, which is not a surgical procedure, but is often offered as a medicalized, very abusive, very harmful treatment. There are laws across the nation that prohibit sterilization, procedures such as psychosurgery, electroconvulsive therapy. And these are all procedures that are targeted for legislative regulation because they are recognized to be specifically potentially very harmful to individuals who who are going to be pushed into undergoing these treatments when they do not have the ability to say yes or no themselves. So there absolutely are laws that target coercive, harmful surgical and other medical care. Although, you wouldn't really call it care in that context if it's abusive and harmful. So we very much see S593 as being in line with those existing laws because it would target a practice that is similarly harmful, similarly coercive, and that should really only ever happen when the individual is able to say whether it's right for them personally. So for those reasons, we're in strong support of this bill, and we ask that you support it as well. And thank you for your time.
Any questions for Sylvan before we move on to the next person? Senator Valverde.
Thank you. Hi, Sylvan. So at the beginning of your testimony, I thought that I heard you say that you were disputing the claim that these surgeries don't take place, any gender-affirming surgeries, on minors don't take place in Rhode Island. Did I catch that correctly?
Yeah, I believe we heard one of the doctors who came to testify in opposition claim that, I think we've actually heard multiple doctors claim that they don't do the surgeries that are supposedly intended to be targeted by this bill, but then they've talked about doing exactly these surgeries. They've talked about doing vaginoplasties. They've talked about performing surgeries on infants with hypospadias, which would be surgeries to relocate or lengthen an already functioning urethra. So it's a disconnect between what we're hearing them claim and then what they're also admitting to, in the next breath.
Is there do you draw a distinction between, what one of the doctors testified about when she was talking about, I believe, not sure the exact term, but a persistent cloaca, and then she talked about surgery that involved a vaginoplasty. Do you draw a distinction between doing surgeries like that in service of perhaps a larger medical problem and just doing it as a gender-affirming surgery?
So I do want to back up quickly and say these are not gender-affirming surgeries. Gender-affirming surgeries are that term refers to care that is provided to transgender individuals who are seeking care on purpose to bring their bodies into alignment with how they personally.
Thank you for clarifying that.
It's appropriate for their bodies to appear and function. The surgeries that are performed on children's variations in their sex characteristics, they're performed primarily to affirm the doctor's and or parents' perception of that child's sex or gender. So I think it is important to be precise about that difference. And as far as extra fee goes, I am not a medical doctor myself. My understanding is that extra fee is a more complicated situation with considerations that may require surgical intervention, such as being able to urinate, in the first place, and to have, internal organs inside the body instead of outside the body. So that is something that I would have to go back to our team of medical advisors with. But as far as I understand it, most components of an extra fee repair would not be covered under the bill as written. Vaginoplasty seems to me, again, I'm not a doctor or a surgeon myself, as is probably obvious. I don't know that a vaginoplasty would be a procedure that would be absolutely necessary to do in the case of extra fee. If there's a reason why that would be true that I'm not aware of, then I definitely welcome input from medical professionals who are affirming of individuals with variations in their sex characteristics who can provide better input on that.
All right, thank you. And thank you for that earlier clarification on the use of the term gender affirming.
Yeah, of course. Thank you for your question.
Any further questions for Sylvan? Thank you for calling in.
Thank you very much.